Let me welcome you all to the 63rd edition of this grand episode with my examiners on the panel. So I'll keep a bit quiet today. Thank you, sirs, for accepting our invitation. Uh, uh, Pawan has muted everyone. The panelists and co-panelists will be able to unmute themselves. The question answers can be posted in the chat box, which myself and Amrit will pick up and put it to the panel. So next slide, please. Let me hand over the session to Professor Dr. Tufan Pati sir from Cuttack. Sir, no explanations, details about you. Over to you, and please keep our intros also. Sir, over to you.
Thank you, Alim. So next, please, Pawan. We have the two vibrant moderators, Dr. Alim and Dr. Amrit, and they are quite well known. And I shall be moving on to the introduction of our esteemed chairpersons. Next, please, Pawan. Dr. Rakesh Lal is MD in psychological medicine, and he is professor of National Drug Dependence Treatment Center and Psychiatry, All India Institute of Medical Science, New Delhi. He has over 100 publications in national and international journals and editor of 6 books. His activities include coordinating the efforts of various ministries involved in substance abuse control, including the Ministry of Health, Social Service, and Ministry of Finance, involved with various international organizations like WHO and UNODC to reduce impact of alcohol and drug use. He is involved in training of physicians, nursing personnel, and paramedical staff in India and Southeast Asia. Training includes both pharmacological and non-pharmacological interventions. He has edited many books to be used as research material for the trainees. Role in formulating the drug and alcohol abuse policies in India and neighboring countries. He is member of national counterparts of WHO and the Informal Scientific Network of UNODC, and is involved in a research person with the Columbia Plan for many years. His chief area of interest is adult substance use, alcohol use, co-occurring diseases, and capacity building. Welcome, Dr. Lal.
Thank you, sir. Thank you.
And we have got with us Dr. Sharma. Next one, please, Pawan. Oh, other chairperson, Dr. Sharma.
Oh, yes. Good evening, sir. Good evening.
Yeah. The serial was a little wrong. Dr. Avinash Sharma is obtained MD in psychiatry from CIP Ranchi in 2008. He subsequently worked as a faculty of CMC fellow and also at CIP Ranchi. He worked in Australia for 5 years, obtaining the Fellowship of Royal Australian and New Zealand College of Physicians, FRANZP, in 2017. He is currently Associate Professor cum Administrative Officer in charge at CIP Ranchi. His area of interest: transcultural psychiatry, psychiatric ethics, women's mental health, mental health, and community psychiatry. Welcome, Dr. Avinash.
Thank you very much, sir.
With this, I hand over the meeting to the chairperson, Dr. Rakesh Lal and Dr. Avinash Sharma. And Pawan, when they introduced our esteemed speaker, Dr. Vivek Pinagal, please display the slide. Now over to the chairpersons.
Thank you, sir. So I think we'll get on with the talk. It's a slightly odd talk in that a young teenager dragged into a clinic and mother suspects of drug addiction. It's odd, but everybody faces this situation. If you have not faced it so far, you're soon going to face it. Because one thing is that any change in the behavior of a person, the first thing you think about, he to drug leta hai, he's a drug addict. And more so for a teenager. And unfortunately, if we focus on that, we might miss out other causes of anger. So that we have to be very careful about. The simplest thing would be to take a blood or urine sample and do the testing and find out if he's taking any drugs. But it is not so simple because the patient may refuse. Like this person was unwillingly brought to the hospital, so he may refuse in which case we cannot force him to give his urine or blood. And so we largely have to rely on the history of the patient, and confrontation will not help. It will absolutely not help. We have to take the patient and mother into confidence, let them feel that we are trying to help you, and convey that we are for you. And later, of course, we can discuss uh, with the patient about his interpersonal problems and family dynamics, but that comes later. Immediately, the patient is with you, and what can be done, I'm sure Dr. Vivek will tell us all the details about how to approach, basically how to approach such a situation. So with that, Dr. Avinash, would you like to say something, or do we hand it over to Dr. Vivek?
Oh, well, I think so. We can get on with the talk right away.
Okay, Dr. Vivek, please welcome, and we'd like to hear you out.
Okay. Let me share screen. Okay, so basically, I mean, why it is not happening? Okay, that's good. So the reason why I wanted to actually do this talk when Dr. Tufanpati asked me was that, I've become sick and tired of doing all these evidence-based this, that, do the, neurobiology, this, the drug dosage outcome, this, there's been a lot of it, and there's been a surfeit of it. So I thought that, it might be useful to give a slightly idiosyncratic view, and let me underline idiosyncratic, because it is more what we, or at least I, do in the clinic, and what I've been trying to teach my students to do for the last 15, 20 years. And so, and then we can discuss, the merits, demerits of it. We can always discuss this. So, as Dr. Rakesh Lal was saying, that this is a fairly common phenomenon of young people being marched in, and marched in without even being told that they're being brought to see a psychiatrist. And it most often happens when you are dealing with people who are being suspected of using drugs, being an addict. And this whole thing of being an addict is something that is earth-shattering, especially for parents. I mean, there's nothing more earth-shattering than a mother saying, "You know what, doctor, I think my son is an addict." It really disturbs their world. And which is why, I start off with this cartoon where this mother and father bring this child in, and the child says, "I'm okay, just leave me alone." Now, what are the things which are going on in the parents' mind? I mean, the parents are obviously, the number one thing is, will my child get hurt? Will I lose him? Will he die? It's a big thing. Drugs are very dangerous things. People can die. People, the core image that people have in their minds are IVDUs, intravenous users, and the sudden deaths that occur to intravenous users. Are our dreams over? And people often think, what will people think? So that there is a huge amount of stigma which is related to it. But also, there is this need to say that, okay, it's not our fault, it's someone else's fault. The drugs are responsible, or his friends are responsible. Her the people she is meeting are responsible. My child has always been very, very good, and there never was a problem until drugs entered the scenario. And unfortunately, sometimes we also get caught up in this in this fantasy that the child was absolutely okay, and then the drugs came in, and then everything went south after that. As far as the child is concerned, child, adolescent, young adult, whatever. I mean, I these days lapse into child because I think I'm becoming like Shobha Srinath. He used to call everybody under 50 a child. So the biggest thing that young people really come in with is this huge ambivalence. And there is one strain of thought. And unlike what Rakesh said, here I have no, I'm dealing with a scenario where actually there is no doubt that the child is using drugs or is using alcohol or whatever. Yeah, what Rakesh talked about is a very, very real thing, but that needs to be dealt with at a slightly different level. And Rakesh alluded to it. I think, that was good that he did. But, most young people who are using substances, they have a huge amount of ambivalence. One is that, yes, it helps me. It helps me, relieve my boredom. It helps me relieve my anxieties. It helps me, feel good. On the other hand, there is this other strain which says, yeah, it gets me into trouble, but damned if I'm going to, admit to it. And there is this whole shame, anger, feeling of rejection that the young person has, which actually creates this whole, and you can see this, ground glass, a wall between the parents and the young person. When the young person comes and meets the professional, there is a different kind of dynamics that happens. And, often what happens is that because of a variety of reasons, we resort to certain things which actually makes communication difficult between the healer, the treatment person, the doctor, the psychiatrist, the psychologist, or whatever, and the young person. And often, the healing person, will resort to things like labeling. You are an addict, and I need to prove that you're an addict, because if I don't prove, then you're not going to accept it. And this comes from a very long history of having people bottom out and therefore accept absolution and salvation. There is a long tradition to getting people to actually admit to being whatever. Then there is a question answer thing. I'll come to each one of these, but then we tend to use some of these techniques, some of these ploys, and that is often met with counter ploys. Spy versus spy in the old Mad magazines. So young people come up with argument, challenging, discounting, interrupting, ignoring, and this whole thing of denial, which really is, blaming out somebody else, excusing oneself, a reluctance to say that, I actually do this, disagreeing with the interviewer, minimizing the problem. It's not such a big problem, and unwillingness to change. And sometimes the worst of all in my book is passively agreeing. I will stop everything from tomorrow. A flight into health to avoid confronting the problem. And this is something that invariably happens in almost every clinic. So there are some roadblocks to reflective listening, which is the need of the hour. And I've borrowed it from the motivational interviewing textbooks. And it's there in all the motivational interviewing textbooks. And the reason why I borrowed it is that I found some of the motivational interviewing principles very, very useful. Not necessarily the entire MET handbook itself, but the motivational interviewing principles of open-ended questioning, affirmations, reflections, summarization, listening for change talk, etc. These are techniques which I really like to teach my psychotherapy students, because this is something that although meant initially for people with drug and alcohol problems, these are techniques which are very useful in any psychotherapeutic scenario. And these are very important skills to have. Anyway, I'm not going to go into details there, but these are some of the roadblocks to proceeding. And these are trying to persuade with logic, argue with the young person, lecture the young person, disagreeing, judging, criticizing, blaming, questioning or probing, order, direct, command, warn, caution or threaten, give advice and make suggestions or provide solutions prematurely. And this is the biggest deal breaker. We need, as soon as we see the person walking in, we know what is right for the person. And without making the grounds for this kind of change possible, we immediately jump in and say, you know what, this is what you should be doing. And that is meant with full frontal rejection. And then we get very upset saying, look, the guy is denying, he's in denial. Sometimes distraction, humor, or changing the subject can be a roadblock, but it can also be very useful, as I will later talk about. Some of the traps to avoid, continuing on the same vein, is the question answer trap, where we are actually trying to trap the other person into admitting that yes, he has a problem. Yes, he has a drinking problem. Yes, how much do you drink? Do you drink every day? What do your friends do? So this pattern of question and answer tends to elicit passivity, where the young person is not encouraged to explore the issues in depth, and the client counselor or the therapist counselor relationship becomes increasingly hierarchical. Then there's the confrontation denial trap. Yes, your mother said you do this. No, I never do that. You were found with a pot in your bag yesterday. No, it wasn't pot. And in any case, I didn't put it there. Then there is this labeling trap. A lot of us, not a lot of us, all of us have been terribly spoiled by ICD and DSM, where any phenomenon that happens, we are trying to make 6 out of 9. And we are trying to label something saying, okay, 6 out of 9 satisfied. I'm happy. Guy has got schizophrenia. So you get very upset when it's 3 out of 9 or 4 out of 9. But this is a very active process in most of us, and a large part of your therapeutic engagement is in trying to get your diagnosis correct, is in trying to make that 6 out of 9, fitment. The expert trap, which is, providing direction to the client, saying, yeah, I am the expert. I know what things are, how things should be. Premature focus. I already talked about the premature focus, focusing too quickly on a specific problem or aspect of the problem. And this is likely to raise the person's resistance and focus on unimportant or secondary problems. Blaming. Usually, clients might wish to blame somebody else. Counselors also feel, or therapists also feel the need to show and to prove that the young person or the client is at fault. Saying, no, but your mother says you do this. You've been causing such a lot of harm to your parents. Look at them. See, they're so upset. So, one response would be that I'm really not interested in looking for who's responsible, but rather what's troubling you. But sometimes we don't do that. We jump in and we take sides. So these are things that actually increase increase the resistance in the engagement that occurs. And so I've quoted Anais Nin, who's a French author, who very famously said, we don't see things as they are. We see things as we are. So when you have this particular scenario, what is going on? What is going on behind each one's back? What are the motives in some of these scenarios? A therapist walks in with a writing reflex. I'm sure all of you know about the writing reflex. It's a psychological construct where most people want to make things right. If you walk into a room and you find a chair turned upside down, first thing you'll do is want to change. If you meet a person whose life is not going right, you would want to do something to change it. This is a very human response. But sometimes in a therapeutic scenario that like the ones we are describing, that can be counter-therapeutic because the other person is not yet ready for change. When a person comes in with a problem, for example, a person who has been having delusions and hallucinations or is very depressed, the person comes in and says, doctor, please help me. At that time, you jump in and you say, yes, do this, raise your right hand, show your face towards the east, have this tablet, do this. The person actually walked in ready for change. However, with people who have drug and alcohol problems, especially young people, they're not yet ready for change. And if you try to write things before they are ready for change, things don't really work out. It's like trying to plant a seed when it's not ready and the soil is not ready for planting. The other problem that I will call it a problem. It's something that definitely happens in younger clinicians, younger therapists, is the anxiety to do the right thing, to be effective. And it's the worry that if I am not able to do something, then there must be something wrong with me. And, I can confess that, very many times in my younger days, more than, and even now sometimes, more than actually looking at what is happening in the transaction, I sometimes try and spectatorize myself and say, am I doing the right thing? What is the next thing I should do? What is the clever remark that I can make? What is the clever comeback thing that, I can say? I don't know who I'm trying to impress, but I am trying to, and it's coming out of anxiety to be effective. It's not necessarily a bad thing. It's something that one needs to be able to acknowledge and move on. Then there is this whole expert trap that I know what's good for you. I have diagnosed you by the ICD. You have 7 out of 9. You definitely have a diagnosis. I know that this particular tablet is good for you. I know this, so you better listen to me. And if you're not, I'm losing patience. And so what comes out is this whole thing of, I'll prove to you, you're an addict and you need to change. Now, unfortunately, that is counterproductive because everybody and their brothers and sisters has been saying the same thing. And for the young person, the response is, hello, you are the 751st person to say that. So please stand in line until 750 have finished. Then I will listen to you. So what happens is these full frontal approaches, tend to be counterproductive. And so the response often is, I am not, and I will fight this label. And as I told you, at the back end, there is ambivalence. It helps me, I like it, it hurts, I've been hurting for a long time. And this is something that we really need to pick up. How do we get there? Now, a slide on denial or resistance. This is a word which is used very, very frequently, especially in the addiction literature and in the addiction business, where people are thought to be in denial, and you have to break people's denial to be able to go forward. Now, as far as I'm concerned, and as far as the motivational literature is concerned, denial is actually a potent indicator of ambivalence. It means that you are in a state of ambivalence. You don't know whether to go forward, you don't know whether to go back, and you're stuck session 2. People are unable to change until they reach a certain level of motivation and they have enough confidence that they have what it takes to make the change. Sometimes I don't want to move because, I'm not sure that what you're offering is good enough. I've got burnt so many times. I'm not sure that, I have the capacity to make the change. So I don't want to change. I'm going to be stuck here. This painful state is actually better than, potential pain that lies ahead in the darkness ahead. So pre-contemplation phase is one of denial. Until the person becomes aware for himself that there are risks involved by not changing or feels convinced about change, they're unlikely to begin the process of change. So people might, when they come into your clinic, may be ambivalent even about beginning the conversation if they're not personally invested. So this is one of the things I strongly believe in, that if there is no buy-in, there is no change, there is no movement. If the person does not buy into the program, he or she is going to do it because you are a great doctor. He or she is going to do it because she's getting banged by the parents. But that behavior change is not going to last. When one lacks motivation to change, the initial goal, which is the first step towards the ultimate goal, should be on raising the level of motivation rather than fixing the problem. Unfortunately, most of us fixate on the problem and want to go directly to fixing the problem. I mean, I've said it a little later, but I'm perfectly, content if the person I'm working with does not want to go to the peak of Mount Everest, I'm happy to go up to base camp. And this is something I keep telling my patients, that I'm happy to go to base camp. We'll go to base camp, sit there, look at the the peak of Mount Everest, and then one day when we are confident, we will go up. So conversations with someone who are not ready to change. One of the concepts which come from motivational interviewing is rolling with resistance. That do not meet resistance head to head. You get stuck there. And this is one very important motivational interviewing skill. I'm not going through motivational interviewing here. I'm just talking about things that I use, mix and match from different approaches. One is to ensure that the approach to helping doesn't become an unnecessary or unhelpful distraction from the help you are trying to offer. Sometimes the method becomes the madness. That your stroke, how you played the stroke, people fixate on that, not whether you got a 4 or a 6 or a 1 or you lost your wicket. So rolling with resistance is a pre-directive strategy used prior to teaching or giving advice. And it's designed to navigate ambivalence, to get around an obstacle, to change. It helps the messenger not become a distraction from the message. So premature confrontation focuses the tension about change on the helper. It becomes about you, not about the struggle that the person is facing. So how can you respond to resistance? One technique that we commonly use is simple reflection. Somebody says something, well, I don't think I can do it. You don't think you can do it. Okay. What next? The simplest approach is to respond with a non-resistance by repeating the patient's statement in neutral form. This acknowledges and validates what the patient has said and can elicit an opposite response. Or you can try and shift focus. You can use this helping the client shift focus away from the obstacles and barriers, which is, you know what, I am very, very angry. I don't want to talk about it. My parents have, brought me and they didn't even tell me they were bringing me here. They said they were going to take me to McDonald's to give me burgers. So, okay, fine. I understand you're very angry. Do you mind if we talk about something else? Do you mind, if I ask you a few questions about who you are? So this offers the opportunity to affirm the client's personal choice regarding the conduct of his or her own life. The other one technique, slightly difficult, is siding with the negative. That is to take up the negative voice in the discussion. I don't think I can do it. Yeah, I think that you're not prepared to do it. Maybe it might be too difficult for you to do right now. If the client is ambivalent, you're taking the negative side of the argument, evokes yes, but I can do this. Who then expresses the other positive side. It's a little difficult. It requires getting used to. And there is this whole thing of reframing. I put it last because I will spend a little bit of time talking about reframing. Reframing is a good strategy to use when a client denies personal problems and by offering a new and positive interpretation for negative information provided by a client. It acknowledges the validity of the client's raw observations, but offers a new meaning. Now, before explaining this whole reframing, because reframing, at least in the way we do things and the way I teach and we teach at our center, some of these interview skills, dealing with patient skills. Let me actually talk about the evidence-based, so-called evidence-based, which for the time being just accept as my core beliefs. Some of my younger colleagues say that these are my delusional beliefs. Perhaps they are, perhaps they aren't. But there is a lot of literature to base this on. And I have previously talked about this literature, and all of you, I'm sure, are very, very conversant with this literature. My first belief is that alcohol, tobacco, and other drug dependence or other drug addiction has very little to do with addiction. So ensuring abstinence is just one step and it's not the goal. right? And let me say why I'm saying this. The sine qua non, that without which there is no addiction, is loss of control. Addiction is just one of the many resultants of a brain developmental disorder leading to psychological difficulties in engaging with multiple demands. And these relate to cognitive control, emotional regulation, emotional recognition, which give rise to a vulnerability and lifelong difficulty starting from childhood, right? And individuals who have this kind of difficulty, remember, there is now overwhelming data and evidence to show that this whole vulnerability is actually transdiagnostic, and it is as applicable to vulnerability to addictive disorders as it is to, say, schizophrenia, bipolar disorder, anxiety, depression, etc., even Alzheimer's. Well, that's a different discussion we can have. But individuals with this kind of deficits discover ways to relieve or self-medicate their strained cognitive reserves or negative mood states. One of the common mistakes that we think is that people use drugs to actually increase their hedonic state, to feel good, to feel intoxicated. Yes, of course they do. Alcohol, drugs, tobacco, other drugs does cause intoxication. But what it also does, and this is the story that is not told very often, is that it increases cognitive control. And which is why when people first use it, and especially young people who use cannabis will tell you that when I start using, my brain fires properly. In fact, many years ago, a young person who had asked is saying, what happens when you smoke cannabis? And he told me, you know what, doc, normally when, I'm talking to somebody, it's like being in a room with 20 people speaking to me on a megaphone. So it's that old. And I don't know who to respond, what to do. And I said, what happens when you take cannabis? He said, at least I can tell them to come one by one. So what he was very graphically and colorfully describing is the change in cognitive control that happened. And one of the reasons why people with this cognitive control deficits, gravitate to cannabis as well as to a lot of the other, alcohol, tobacco, other drugs, as well as internet gambling, etc., is because by increasing dopamine in the reward circuit and by increasing dopamine, it actually also increases or improves cognitive functioning. So regular use by a young person whose brains are still being formed results in long-lasting neuroadaptation due to early repeated exposure. And these lead to long-lasting changes in brain networks, behaviors, and habits, which then constitute the addictive state or the dependent state, whatever you choose to call it. So my point for making this long observation is that just getting rid of the bottle is not going to solve the problem, because you get rid of the bottle, the core problems that were there in the first place will ensure that the person relapses, and you will get what you normally get, a revolving door kind of process where the person goes, gives up the bottle, comes back again. Then he goes, gives up the bottle, comes back again, leading to immense frustration and distress in the client and the parents and the family, and to therapeutic nihilism in the treatment professional. So, I mean, I don't wish to go into the details. This is just a chart that was there to remind me of what I've already said, that, you have this change, this whole process where genome, exposome interactions change brain developmental trajectories, etc., etc. I've discussed this on many fora, even in this fora. I'm not going to go into it, but it translates into parental and child concerns, which are related to the fact that there is a lot of stigma, there is risk perception, varying risk perception related to health, mortality, legal aspects, etc. And there are difficulties and failures in which are there, and often it is attributed to the drug, it is attributed to the substance. But if you push back a little, you ask questions a little, you will find that parents and children actually acknowledge that these are long-standing difficulties. long before the first sip, long before the first drag, long before the first, playing with PUBG. The other core belief, which I said earlier, is one need not reach the peak of Mount Everest on day one. Let's first get to base camp. So I strongly believe that I need to be a good doctor, not to prove it. And it's okay if I don't win today. The world is a circle. So I have no qualms about not making the deal on day one or day two and saying, okay, fine, I agree to disagree with you. And if you have the need, come back. I'm sitting here. You will find me on Thursdays and Saturdays from 9 to 3. So please feel free to come back. And the good thing is that 99% of people come back. And there is a moral in the fact that if you keep a bird in a cage, the first thing that the bird wants to do is to fly away. If you just sit there and give water and seeds, the bird will keep coming back. Anyway, so that's apart from that. The other thing is that any sales agreement which is predicated on the barrel of a gun has a very short life, especially with people who are notoriously unable to sustain motivation in the first place. The third statutory disclaimer is that you cannot cure addiction or anything else for that matter by punitive action or locking people up, but you can definitely mutilate them for life. The big problem with drugs, of course, is that they're illegal. The war on drugs treats users as enemies and criminals. And yes, I mean, there is no doubt that they have medical consequences like salt, sugar, fast food, and alcohol. But at the end of the day, it is not my duty to get rid. I have not taken a theka to rid the world of alcohol, tobacco, and other drugs. But I certainly have a duty to work with people to get control back into their lives. And so, in a way, this is something that I'll keep talking about, is about cognitive control and how to bring control back into people's lives. The parents, on the other hand, are often scared to entertain the thought of difficulties from childhood, as they are worried that it is an indictment of their parenting efforts. That if you say, no, has he had this problem for a long time? Has he had difficulty? No, it is only after he started using alcohol or drugs. It's only after he started, playing with these other children. So they're safer putting the onus on the demon drug or the devilish others who have led their children astray. But they get very baffled, hurt, and rejected that their children reject their advice, don't have the moral strength, and keep relapsing. And they feel relieved when they have a new explanatory model which is not centered on the demon drug and explains the long-term and short-term problem, and also has a possible strategy to deal with it. So that brings me to my opening line. So when people do come, yeah, especially the young person does come, I often starts with what brings you here today, which is, tell me what brought you here. And yes, I'm willing to accept that I didn't want to come. So that I realize you got dragged in against your will, but thanks for coming anyway. No, I don't want to do anything. It's my parents. Okay, so that's your parents' point of view. What is your point of view? And if we get that conversation going, you start off with this whole decisional balance thing in motivational interviewing. Again, that today is not the day I will do it, but that starts off with, so what's the good thing about your use of substances? How does it, what would you miss if you were not able to use cannabis, for example? So you work this decisional balance for forces for and against the person's use of the substance, as opposed to his or her goals and where he or she wants to get. But these days, I actually go off in a slight tangent, and that is because of all the other things that I've learned and all these core delusional beliefs that I have. I actually do a lot of reframing, which is MI plus, if you might consider that it's not classical motivational interviewing, motivational enhancement therapy. It's some things that we have added over the years, as information and facts presented themselves to us. So I often go off and I say, do you mind if I spend a little time getting to know who you are? You as a person, I mean. Okay, so can I ask you a few questions to get you onto some things I'm really interested in knowing about? And there, what I do is actually I go through some of these, some of these things which are, questions on temperament. So, are you less or more in terms of are you more impulsive or less impulsive than other people your age, your background? Do you have difficulties, or are you good at sustaining motivation, starting things off? Are you able to finish things, or halfway through do you lose interest and you just stop what you're doing and you want to go off onto something else? Do you procrastinate a lot? Do you find that you are bored most of the time, and that you have very, very low threshold for boredom? That most things don't really excite you too much? Do you find that your moods are constantly swinging? Do you find that that you're very sensitive to rejection from other people, whether they really reject you or you're scared that they will reject you, and then you become very sad, upset, or you become very angry, and you're moved to do things like slashing your wrist, breaking the TV, etc., etc.? Or do you find you are very, very sad and depressed, or you find that you don't want to do anything, you don't want to try anything because you're anxious that you will be rejected? Do you find difficulty in reaching your goals? Do you find difficulty in holding on to relationships? And that actually works out this whole thing of cognitive deficits, cognitive control difficulties, emotional regulation difficulties, as well as difficulties in emotional recognition, which actually results in poor empathy, reduced theory of mind. And the reason why I do it is that we now know that this is at the core of almost 99.9% of people who will go on to develop alcohol and drug problems, as well as do a whole lot of other things like, it's at the core of a lot of other pathology, psychopathology. So I then reframe it with an alternative explanatory model. The person came in saying, okay, the problem is about alcohol and drugs. The problem is about the bottle. The problem is about the my bong. And then he finds that I'm not talking of the bottle, I'm not talking of the bong, I'm actually talking about a whole lot of other things. And most of the times, these young people who've suffered this all their lives and have never been able to put words to their suffering, or have not been able to discuss this, turned around and said, oh shit, how did you know? Yes, this is what has been affecting me. This is what has actually prevented me from being the best that I can. This is the thing that has not allowed me to live up to my potential. This is the reason why I have not been able to win the prizes. All the duffers have been walking around, going away with the prizes. And I'm definitely more intelligent, more creative. I'm left back with nothing. So I take that point, and I'm not saying that everybody has to do this, but I personally take this as a point to say that, can I give you a 3-minute lecture on the brain? And I basically talk about how, parts of the brain are like the car, engine, accelerator, brakes, and gears. And there's a part of the brain which motivates you to do something, propels you for natural or, unnatural rewards. There are parts of the brain which are like the car, which brake you and say, hang on, wait, watch, and then do. There are parts of the brain whose job it is to be like the gear, which switches from one to the other, switches from first gear to second gear, and which actually ensures that when you need to switch from very exciting to not so exciting, your car still goes towards its goal. So I use this, and I also use another story about how our autos have 2-stroke engines and are not very good. So a lot of people use kerosene, which is aeroplane fuel, which makes the auto zoom. But over time, the kerosene makes the 2-stroke engine worse than it began. This is an analogy for the drugs. And using simple examples like this, what happens is that you're able to actually to share a worldview, to share an explanatory model. And then most people turn around and say, okay, that's me. Tell me what to do about it. So, and that is what you wish to do when you are getting people to change their, what's the thing? Going from contemplation, pre-contemplation, etc. Those stages of motivation. So I these days tend to use this kind of a thing to actually increase people's motivational stage, as well as give a sense of a particular explanatory model. Why? Two reasons. One is it's reframing. It's very different from the explanatory model that they had, and so people respond to it by saying, "Wow, I didn't know that." That's convincing. The second thing is that it actually has embedded in it a call for action. That if this is what is happening, then something can be done about it. And of course, there are some people who don't agree, and I'm happy to say it's okay if you can't make up your mind. I'm here 9 o'clock to 11 o'clock on Thursdays and Saturdays. Anytime you want to get back, have a chat, please do. I'm giving you a WhatsApp number. Please WhatsApp or email if you have a question. So then we start. What I will do here, what is the time now? It's 9:15. What I'll do is I will present very briefly three scenarios, three case histories, just to illustrate, how we went about it, how we go about it, and then we will decide whether there is enough time to show you some videos or not, or whether you are so bored that you don't want to go further and go straight into question and answer and discussion. So let me talk about three of my young patients who I could recall. Miss SC was a 15-year-old female, multiple drug abuser. She was actually a girl from a high socioeconomic status, and she was brought straight from a rehab center. Straight, from the rehab center, they sedated her. They actually taped her hands together, legs together, plonked her onto a plane, took her straight to the airport, plonked her onto a plane, and brought her direct to the OPD. I thought that was really crazy. This is the craziest I've ever dealt with in my life. She was brought straight from the rehab center, from where she was doing her class 10 exams, and there were major questions about safety and escape from custody in the OPD. They even had problems about opening her, that silver tape that you use, no? What's it called? Duct tape in the OPD. She had been treated for multi-substance dependence, inhalants, cannabis, tobacco, and alcohol, and had very severe emotional reactivity with violence to self and others. She had been diagnosed as having borderline personality disorder and had had multiple admissions in rehabs and psychiatric nursing homes. She had very early sexual experiences with multiple MTPs. When she came, she was in a combination of 2 antipsychotics, carbamazepine, and was on long-term psychotherapy. The parents came because they thought NIMHANS would give them long-term confinement and care, which we don't, by the way. On MSc, she was an overweight teenager, over-sexualized clothing and appearance. The dominant theme in her conversation was her reaction to the male parents' affair with somebody else, with another lady, and her feeling of temporary abandonment because he had left mother and the 2 children and gone off. She was very angry, blaming her mother and father, and she was spouting psychobabble. I think she had psychology as one of the subjects in a course, and she was know-it-all. And I know you're going to do this, you're going to do that, you're going to do a Rorschach, and you will do this, da. What the interview revealed was sadness about now unrealizable dreams and goals. And there we use this entire motivational interviewing as well as this whole reframing. And she said, look, I'm not going to be able to realize my goals. This is what I wanted to do, but I'll never be able to do that because I'm an addict. The ASRS, the ADHD self-rating scale, showed very high scores. And these were amplified by questions about impulsivity, poor attention allocation, and an inability, and it pointed to an inability to achieve her hopes and goals despite a very high intelligence. So we reframed this inability to achieve hopes and goals as the central tragedy in her life. And she readily agreed. She, agreed to the explanation of the brakes and gear problem and drug use as self-medication. And she turned around and said, okay, fine. So what do we do? And we agreed to work on tuning the brakes and gears while placing a reduction of drug use as a why use kerosene instead of petrol argument. I was very careful not to say you have to stop using substances. I never do with most people. It comes either as a suggestion from the young person or a question saying, do I have to stop this while I'm doing this? So we sat down, and in that OP interview, we set a few goals. And the goals were that we will do the brakes, gear, and tuning with a combination of several things: medication, which is very important, because these are, whatever the explanation you choose to give, because it will make the stage, the reason why you can't achieve anything, including your therapeutic goals, is because your stage is shaking. So it doesn't matter whether you are dancing Kuchipudi, Bharatanatyam, or Odissi, until your stage stops shaking. And the medication will allow us to help the stage stop shaking. And after that, we can decide what dance you want to dance. And then we bring in brain training, diet and exercise, especially omega fatty acids, adopting positive highs, positive addictions, and learning skills to learn and achieve various things. Basically to deal with the cognitive deficits, to deal with mood instability, mood regulation, to learn how to actually assess other people's emotional states, and to be able to amplify your theory of mind. We also work very strongly on lapse or relapse management. One of the things that we do accept is that this is a relapsing recurrent illness, like bipolar disorder, like diabetes, like hypertension. And while you detox and help reverse brain changes due to drug use, lapse management and aborting relapse becomes a very, very important part of any treatment process. And that is something that is better done if it is in consultation with parents or various whatever our support structure is. We also worked on confidence building measures, and this is what Rakesh was talking about, and lifestyle changes. So the biggest casualty that happens is a reduction in trust between parents and children. And the most important thing and the most difficult thing to do is actually rebuild that trust. And so we worked on certain things which help rebuild the trust. And often the easiest thing in the world is 2 drops of urine. Because if you are able to show to your parents, whenever they want to take the thing, or at a given example, that, I haven't taken a drug, I haven't, my urine is clean, then trust builds up very, very fast. And most young people are, willing to do that because it's a very cheap way of, getting trust back. Provided, and there's a provided it is a favor that they are doing to their parents. This is a favor I'm doing to you. You are not making me do it. I am doing this, and this is a gift I'm giving you, which is fine with the parents. But that can go a long way. So these drug strips, etc., are very, very useful, including if you have the access to it, things for alcohol, tests for alcohol, etc. Then we settled on some short-term and long-term plans. We set boundaries, because you have to set boundaries, and the rights and responsibilities were reappraised. I must tell you, and this is about this young person. When she came, as I said, she was around 16, 17. She is now around 27. She went back to Calcutta to finish her college. And then from there, she went ahead and did her master's and her BA in the UK in management. And then right now she's running her father's firm in Dubai. She continues to use substances once in a while, Of some days, she, when she was in college, she would get pissed drunk on Friday evenings, but never on a Saturday because Saturday, Sunday, because she had class on Monday. And even now, she once in a while, likes to have a spiff, those big fat. But most important is she's got her life back on the rails. I have not been able to make her fully abstinent, but I think she's in a better place. She's in better control of her life than she was earlier as a 16-year-old. This is 9 o'clock. I will do two more, at least one more vignette, and then I'll stop. I don't think we'll do the videos today. This is Mr. A. He was 17 years old when he came in, again, multi-drug user, was brought to the OPD by his parents because they had learned he was using cannabis and he'd been suspended from school. He'd been brought to Bangalore on the pretext of visiting his uncle and aunt in the city, but instead of going to his aunt's house, they came straight to NIMHANS. You can be sure that the boy was upset and angry. While waiting in the OPD, he actually walked off and he refused to make eye contact with his parents. His parents were insistent on immediate admission and throwing away the key, citing that his drug use was too serious and that they could no longer manage to deal with him at his home. His school, by the way, had suspended him for missing the latest exam. He himself appeared both angry and anxious during the interview, but once rapport was built, he was assured that he was being listened to. He reported that he'd been using cannabis in a dependent pattern for the last 4 years, with occasional use of cocaine, salvia divinorum, and a combination of LSD with amphetamines at rave parties. He'd always been very shy and had almost no friends at school growing up. The peer group he'd found was into drugs and raves, and he'd got along well with them while using drugs with them. He eventually found that he was procuring drugs for them to support his own drug use, but he was ostracized by almost everyone else other than his druggy friends because he was a pusher. The dominant themes from his history, there was significant history of difficulties with concentration, which interfered with his academics. He had said that initially it was better with cannabis, but now with continued cannabis use and other drug use, it had worsened beyond belief. He had a high degree of performance anxiety. He'd bunk exams as he could not bear the thought of writing them unprepared. He had a difficulty talking with his peers and teachers. He felt upset at the frequent fights between his parents and could not confide in them. His father's behavior distressed him. Most as he became irritable and later end up crying whenever any controversial topic was discussed. He had considered suicide as he could not face all these problems. When we assessed him, he had very high ADHD scores for both impulsivity and inattention. Actually, he had also a whole lot of other things which would have made diagnosis of UPD as well. Anxiety was also found to be rated high, and he was a source of significant impairment and distress. And there were depressive symptoms in the father and significant marital discord. We reframed the problem as, a problem of ADHD, anxiety, and whole allostatic, process that happens because of it, and how that exacerbated the developmental vulnerability that he had, which is the cognitive control problem. And we reframed the problem as that this was the core problem which was causing academic and social dysfunction, as well as, laying the grounds for substance use disorder. The intervention consists of reframing. He accepted help for problems with concentration and anxiety. He wanted to improve the relationship with his parents, and the parents reframed the problem as a common one. That yes, if it is a problem about his not being able to focus, is not being able to do, that's okay. I mean, that is something that we can we can do something about, and it reduced the blame on them. And he was also willing to consider using drugs. He was one of the guys who was saying, "Doc, you're not talking about using about my drugs. Don't you think I should do something? Otherwise, the treatment will not happen." So I said, "Yeah, you brought it up. I didn't. It's something you said. I didn't bring it up. So what are you willing to do?" The intervention consisted of psychosocial treatments, individual therapy on an IPT model, interpersonal therapy model initially. Later, we used a CBT model for anxiety and family therapy. We treated the father's depression, and we used contingency management. Pharmacologically, we used baclofen because, as you know, we use baclofen quite a lot. We put him on methylphenidate, sustained release, up to, it's not 20 milligram. We actually put him on almost 40 milligrams per day. And he took on alternate highs of swimming and going to the gym, long-term follow-up with a single therapist, and confidence building measures, quality time with parents, regular polykit tests, emphasizing openness about disclosing lapses. Now, I think those two are enough. I mean, if you want, we'll talk about the other one, but I think it'll get boring. So I think we'll end here and open it up for discussion.
There are
Right.
a lot of questions in the chat box. Vivek, do you have access to the chat box, or should somebody?
I have. Let me open the chat box and see. So
Yeah. There are a lot of hello messages, but then there are a lot
yeah,
of
hello
good,
messages are most of it.
There are a lot of good questions also.
Yeah.
So
The-
so if you
Abhishek,
could-
the first part of SBI is asking screening questions. Is it also a question and answer trap? Yes and no. See, these are actually by SBI, you are referring to screening and brief intervention, isn't it? Abhishek? Your new message has gone way below.
he said yes.
He said yes.
Yeah.
See, screening brief intervention is a slightly different model, and screening brief intervention is something that you use in the community for people with harmful hazardous use. It is used by people with in primary healthcare, whereas we are here talking about people with severe problems who come to tertiary healthcare settings. So again, when you are going and doing screening brief intervention, remember, people are coming asking for help. They are coming and saying, you know what, I've got diabetes. You know what, I've got a pain in my knee. And the doctor at that time, if he's asking, do you also drink alcohol? It's perfectly within his or her rights. But as psychiatrists, most people don't think that we should be asking them about, their normal day-to-day functioning. Whether I use alcohol or not is none of your bloody problem. Whether I sit on the internet, who are you to ask me? So you have to create the grounds in this kind of a scenario. So the scenario also matters. What's the term for it? The context matters. And so I don't know whether I've answered your question. I'd be happy to take that further. But the next question, most family of addicted person say person is problematic only when he is drunk, otherwise he's fine. Exactly. You're absolutely right. Because we are trained to see drug is the problem. There are two major contending ideas in our mind. A, the drug is the problem. Demon drug is the problem. And therefore, if you get rid of the drug, everything will be okay. And that leads to models like prohibition, etc. The other one is that the person is the problem. And it's because the person has a weak, weak morality, etc. And therefore, we can actually, get the person to hook up with a higher power and, do a whole lot of things and do stuff. I am not, by the way, I am not criticizing any of these. I'm saying that these are limited models. And so when people say that, the drug made him do it, they are hooking onto one of these popular beliefs that the person is absolutely okay and he's a saint unless he drinks. And which is also true, that the person doesn't go about beating people, hitting people, etc. when he is not drinking. However, if you go back into the whole history, he's not been making a too good a time of his life in terms of his job, his education, etc. Because of the cognitive control deficits. And people really don't bring that into the discussion because that is not within the ambit of the discussion. We are here to talk about drug abuse, alcohol dependence. Let's not talk about life, liberty, and the pursuit of happiness. But as people who now understand that most psychiatric disorders are part of this whole neurodevelopmental continuum, we really need to be able to cast our eyes wide, cast our net wider. We need to be able to understand that, for example, childhood adversity is one of the biggest predictors of adult psychiatric disorder. And one of the reasons that it happens is because childhood adversity through inflammation during the time when the brain is being sculpted, changes microglial function, which then sculpts the brain in a different manner, which means that your brain networks behave differently, which means that your psychological functions are different. When faced with day-to-day challenges, you respond in a different manner. We need to be able to have that. And in a way, this new explanation actually incorporates a whole lot of other etiological theories of social theories, biological theories, genetic theories. We are able to put all these things together because, in a way, I speak a little bit too much about it because this is my, the most important thing that I am interested in. In a way, everybody, as they say, all the theories are right. Everybody has one and everybody should be given a prize. But anyway, second, that's a mistake. Your core beliefs are fantastic. Okay, thank you. Some people think they're delusional. Many times, family members are approaching a doctor to do a miracle in the first setting. Okay, this is also a very important question. Yes, most people come and say with a fracture model. If I have a fracture, you better do something. Put a plaster cast, do a pinning, and get things all right. If the person relapses, then it's a problem because you're not a good doctor. So one needs to discuss this with parents. And one of the things that we do is not just talk to the child, but also talk to the parents and lead them through this equal discussion. Sometimes I get the child to say, look, will you please summarize what we spoke about with your parents? And then I spend almost equal time with the parents, trying them to also buy it. And one of the things that we do discuss is, look, this is not magic. You're not going to get immediate answers, but things are going to improve, and these are things that need to be done. Most parents are so happy that A, they are not being blamed for it, B, that there is a theory behind it, and C, that there is a plan, that they don't really sit on your head and say, you must do it in one go. But it's an issue because they've suffered so long. They want fast relief. But if you explain and you talk it over and you tell them that there's a method to your madness, most people forgive you and listen. Complete new understanding of reframing. Okay. Tempted to try it. Abhishek Ghosh, please do try it. Does your approach change when the client has comorbidities? No. The approach doesn't change when this was Madhavan. Madhavan, my approach to comorbidities has changed. If I might, sorry, I'm going to give you a slightly roundabout answer. As you are aware that, most of the studies, longitudinal studies of psychiatric disorder, like the New Zealand Dunedin study, etc., show that most psychiatric disorders do not exist on their own. This is a mistake. This is a delusion which has been foisted upon us by the ICD-DSM and which was started actually by Kraepelin. But in real life, these and it's made life easier for us in a clinical thing. I mean, there is no denying that this in a clinical scenario, this has made life easy for us. But if any person has one psychiatric disorder, there are, I think, almost 50% chance that he or she has a second one. If people have two, there is a 40% chance that people have a third one. If people have three, there's almost a 20% chance they have a fourth one. And what we really do get, and which is why people now have started talking of the dimensional models, and which is where the models like HiTOP and others come in. So most people have comorbidities. This old thing of comorbidity is that if you have substance abuse and you have some other psychiatric disorders. Now, 99.9999% of people with substance abuse have comorbidities because that's the reason why they have developed problems with substance use disorders. A large proportion of people use substances or use the internet or use, sometimes gamble on Diwali nights without anything happening. People who have cognitive control deficits go on to develop problems, as I've already said. So, no, my attitude or my approach does not change when people have comorbidities. Yeah, to a certain extent, if the guy has come in with severe mania, and I would, before doing any talking, first of all, I would control the mania. If the guy is, severe paranoid schizophrenia, I'm hardly going to talk about various other things until I've dealt with the paranoid schizophrenia. To that extent, yes, you're absolutely right. You need to, handle what is there first. I mean, in the same way that if a guy comes in with delirium tremens, you're not going to sit and hold his hand and talk all this nonsense. You are going to deal with the delirium first. How to deal with excessive addictive use of internet and social media among teenagers comorbid with depression, anxiety. Again, I these days do not make. I mean, we can split hairs and say, okay, behavioral addictions are different in this way from substance addictions, but basically, at its core, at the brain level, loss of control is loss of control. Whether you have loss of control with alcohol or tobacco, or you have loss of control with sex, or you have loss of control with exercise. Loss of control leads to a whole lot of these other processes. Yes, depending on what substance you're using, the toxic effects of the brain are going to be different. Alcohol is definitely going to cause a lot more toxicities than, say, cannabis, and definitely going to cause more toxicities than say exercise addiction. Debatably, I mean, we can debate that. A few can still can still try a few innovations you suggested. Okay, fine. That's a comment. Prasad makes a comment. Hi, sir, I have a question. I have a 17-year-old female client with screen addiction, insomnia, eating whatever, cutting on her thighs. Her responses towards me are formal, warm, and respectful. During the first 2 sessions, she remained silent for the entire 40 minutes, and I went along, said I'm okay with it, and she can open up and talk. After 12 sessions, step by step, she agreed to her behaviors, but when I asked, how do you feel about it? I don't know. Looks like it is a coping strategy. That's right. I mean, if you leave it open-ended, she's going to say, I don't know. If you've had 12 sessions without coming to some sort of a agreement, probably you've left it a little bit too long. But then, I mean, you can definitely come back. And one of the things, like I said, most of what I do is in the first or the second session, and which is my reframing helps. I'm sure a lot of you are going to get angry with me, but the old psychoanalytic technique of you say what you want, I will write down in my book, and probably was meant for a different time when people had lots of time, and especially when you're getting $100 a session. Oops is right. Somebody said oops. Elderly parents are being abused by a grown-up son. He refuses to go to any rehab or doctor. What do we suggest to the elderly parents who are willing to let go their son, but he doesn't leave them, but abuses them? Okay, now this is a slightly different problem. This is a problem. Yeah, I think you can work the same kind of thing with the young person, because but there will be some people who say, no, I couldn't care less. I'm going to go ahead and do what I want to do. And sometimes you will have to wait for them to come back to you. But here, if the person is beating up his elderly parents, this becomes a law and order issue. And at one level, I think you really need to be to first protect the parents from getting bashed up. So, this is slightly different from what we've been talking about. In the same line, but the priorities are like, dealing with delirium tremens or dealing with mania. You have to deal with the immediate cause first. Once that is settled, we can go on to other things. Agreed, but SBI may also happen in colleges. Abhishek Ghosh, colleges are not dens of psychopathology, as much as you would like to say. These are also, community and you are looking and you're doing a screening there. And most of the people who are actually coming for your screening SBI are people who have agreed to come there. So in a sense, their level of what's the term? They are not in pre-contemplation stage, etc. They are in action stage. Okay, I think I've run. No, there are more messages.
So messages are coming in. They are pouring in.
Okay. How to break it to parents that the problem didn't actually start when the young adults started using drugs. So this is very important. So basically, the same thing that you use with adults, with the young people. You say that, okay, fine. I am concerned about these drugs and we shall talk about it. But madam, do you mind if I ask you some things, if I might clarify what I asked your son a little or your daughter a little while back? You know, I was asking him about, you know, how he sees himself as a person, his personality, etc. And especially, you know, how he was when he was young. And I'm very, very glad that you are here today because it allows me to actually corroborate what he's saying. So do you mind if I ask you the same question that I asked you? He's sitting here next to you. So, I mean, we'll see, you know, whether the two of you agree on it or two of you have different viewpoints. And I then ask, madam, what do you think? I mean, when your child was young, when whoever, Abhishek or whoever was young, was he less impulsive or more impulsive than other? It is usually what happens very fascinatingly is that the parents, and especially the mother, will say, no, he was perfectly okay. You're a very good boy. And then you will find the child next to him, next to her saying, no, actually I had this difficulty. Where did you have this difficulty? And they'll say, oh, yeah. You know, he would start doing things and halfway he would, he would buy cricket bats, play for 3 days, and then he would, throw it and it would never be used. I once, you know what, he said he would learn a guitar, he bought him a guitar, even 1 month he didn't use it. And then it comes out. And so we say, yeah, is that a problem? Do you think that prevented him from being the best he could? Because your son is fairly intelligent and he seems to be very creative. Then the penny drops. You know, there is 2 seconds of silence. Adam apple bobs a little. I mean, women don't have Adam's apple, but whatever. The throat bobs a little, and women have Adam's apple, not prominent Adam's apple. Anyway, throat bobs a little. They consider it and they say, yeah, he has had this problem from childhood. And then that opens up and you can start discussing. How do we intervene to stop the blame game? Yeah, so this is how you do it, because once people realize that this child is
can we stop the screen sharing so that we have you on the full view?
Oh, sorry. Wait, I just stop share. Okay, you should have told me this earlier. Okay, sorry. So what do I bring up now? I bring up the questions.
Yes, sir. Persons has problem scapegoating.
Oh, yeah, 1 minute. I have lost the chat. Okay, chat.
This is from Dr. Shalini. A person has the problem. What is scapegoating?
Yeah, so the scapegoating, you know what the scapegoat was. The scapegoat is something that in ancient Jewish society, every year they would place their sins on a goat and send it out. So in a way, this whole thing of scapegoating came that somebody is being made the scapegoat or the person who bears the sins of the family or the parents, etc. And to a certain extent, young people who use drugs definitely become the scapegoat. And so one of the good things that I find with this model is that it points to a brain pathology, something that people are not totally in control of, but can be in control of. So at this stage, somebody from the audience usually pipes up saying that, you mean to say that we should tell people that they're not responsible for their problems? No, I'm not saying that. I am saying that they should be responsible, but they have difficulty in being responsible. And so how can we make them more responsible, have more control? But net, what happens when this kind of a of an explanatory model is used, parents feel quite relieved, really, because all the while they've been suspecting that it's their parenting which caused this problem. Perhaps it did, perhaps it didn't, but this model doesn't really talk about parenting as the major problem. We bring it up later saying, look, this is one of the not so helpful things, why don't we work on that? But that scapegoating also stops, because then they are able to look at, they engage with what is happening and they're willing to help the person. Because from a very dirty person who is using the devil drug, you become a person, my own child, who's had a problem from childhood, not been able to recognize it, but you are saying that, we can do certain things to help him become successful again. Most Indian parents want their children to be successful. Most parents do. And so when that comes into the equation, people usually change their minds. Not everybody does, I'll be honest with you, but it is a helpful model to use. Okay, so Shalini says, I agree, pure free association alone does not help. Very true. Safest and effective anti-ADHD drug among addicted adolescents, is there any difference? Yes. So, I mean, the jury's still out, okay? As far as ADHD drugs are concerned, what is true for children is true for adults. I think there is enough literature to show that methylphenidate seems to be very useful among the drugs we have. I'm not talking of the amphetamine salts. Methylphenidate seems to be the most useful. There is a great anxiety that people will develop addiction to methylphenidate in the way they develop it to cocaine or to other drugs. Now, again, the literature is very clear that the chances or the actual addictive use of methylphenidate is very, very low. Having said that, of almost, I don't know, would have used methylphenidate on almost, 700 to 1,000 people, I can name 2 people who have gone on to develop very, very severe methylphenidate addiction. Both of them turned out to have, to head towards schizophrenia. And to a certain extent, perhaps we missed the diagnosis of schizophrenia. But to a certain extent, some of, a lot of these psychiatric disorders, change along the way. And that is also something that we know from longitudinal studies. There was some literature which said that methylphenidate is much more useful in people who have, predominant impulsivity, and atomoxetine seems to be much more useful in people who have difficulties in motivational control, etc. But the literature there is not as strong, although we have a paper on that. If teen used inhalants and other drugs and develop cognitive impairment, yeah, so that is a problem, that people with cognitive impairment, people with mental retardation, etc., you can't do the ideal thing. And for that matter, people who come from low socioeconomic status, who have to work for a living, there are, what we are talking about is an ideal scenario. You sometimes can't do everything because of a whole lot of things, not necessarily because of intellectual disability, but there will be people who will not be able to afford the medication that you want to give them. There will be people who will not be able to come for the psychotherapeutic sessions that you want to do with them, once a week, once a fortnight. They might not even be able to come once a year because they come from some far off place. So yeah, so this needs to be balanced with reality. Any impact of AstroChart addiction? Now, this is something that is beyond my pay grade, so I cannot answer this question. Okay. Anything more?
There was a question on any dietary interventions, any diet modifications.
So okay, fine. This is interesting, and the literature for this is still developing, but definitely the literature on omega fatty acids is very, very interesting. I won't say that it's 200% convincing, but it's interesting enough for us to use it as part of our daily treatment regime, because there is fairly good evidence which shows that omega fatty acid dietary supplementation, especially omega-3, does improve cognition and cognitive ability. Not just in children, it's been tried in senior adults, AD and all that. So there are some groups which are trying to see whether this can be used as a preemptive treatment. The other evidence is for choline, but choline seems to be much more effective. And these are two papers. One came in Nature, and the other paper I think came in American Journal of Psychiatry, where they looked at choline supplementation in mothers in their second and third trimester pregnancy and followed the children up, and they found that children at ages 1 and ages 6, if I'm not mistaken, had lower cognitive deficits, which were precursors to other psychiatric problems than mothers who were not on choline. So there is some logic for that. Plus, there is a lot of literature on dietary interventions in ADHD and other things, which again, magnesium, zinc, but they're fairly wishy-washy as of now. Exercise. There's quite a lot of evidence in the use of exercise in actually increasing white matter myelination, which seems to be one of the reasons why these problems happen. So what we do is actually set up people with medication, dietary supplementation, exercise, positive addiction, and learning skills to deal with, whether it's CBT related. We still don't tell anybody, but we steal blindly from CBT principles and DBT because they have some very, very useful exercises, useful things which can be used in this population. And of course, all the other things, we trust building measures, doing urine toxicology, urine strips from time to time, ensuring that you come back regularly, see the same therapist. If and the most important thing that I forgot to mention is dealing with lapse. Lapses will happen. This is a lapsing disease. All psychiatric diseases are, but do not allow lapse to become a relapse. So most families are told that if the guy lapses, don't wait, thinking, okay, we'll try another day, we'll see one more week, because by that time it's become a full-fledged relapse. So day 1, day 2, if you are in Bangalore, please bring the guy back. And what my rule of thumb is that if you've lapsed for 1 day, get admitted for 1 day and get out. You don't have to go through the entire process again. All I need to do is to break the cycle briefly. The other thing is, there's no other thing. We actually go after people. So we have a set of people on the phone who ring up and say you've not come for your appointment, and we found that this actually improves retention. So a lot of things need to be done for retention. But let me end with something that I found useful. Earlier in my life, as a young psychiatrist, I used to lean forward and try to convince people very much. I was leaning into people's faces and I was being proactive. And I was very anxious that, if I didn't do it right now, I would be a failure. People would think I was a failure. I would think I was a failure. And all the time I was thinking, what can I say? What is the next thing I should say? And one of the things that time has taught me is to lean back and be reactive. Because ultimately, the world, as I said, is a circle. The guys want to come back if there is comfort in the relationship. So with that bit of philosophical nonsense, let me stop there unless there are some questions, other questions.
There were two, if you're able to take it. What is the
Sure.
contingency management plan that you follow in your clinic, and what are the positive highs?
Okay, so contingency management, I used it a little loosely, but then it is a contingency that a lot of things. So this whole contract, we build a behavioral contract, and a lot of the things are built into. So your pocket money is contingent on your returning a drug, returning a blank on your toxicology test. If you come late, when you said you will come at 12 o'clock from a party, if you come in at 12 o'clock, at 2 o'clock, then I have no reason to give you the pocket money. So this kind of things are built in, and so we insist on a contingency contract, a behavioral contract that people try to live up to. Well, it's a work of art in progression. Not that everybody gets it right the first time, but it works. The second thing, sorry, what was the second question you asked?
What are the positive highs that we can talk of?
So the positive highs are many, many. I mean, anything. I mean, it can be art that the person likes to do. It can be, working with some people who are actually making these computer games, and these people go there. It could be hiking, it could be mountaineering, it could be anything. It could be actually working out and helping other people. So whatever floats your boat. It's not something that it's something that gives you a sense of purpose. And remember, a lot of these young kids don't have a sense of purpose. And we found that to be useful. And now there is a lot of literature coming up as to how this kind of positive purpose, positive psychology, so to speak, actually improves improves inflammatory cytokines levels, and it actually improves the activated state of microglia, which during stress become very active and start chomping up parts of the brain. So there is a method to that madness.
Yeah, and sir, one positive high has just been mentioned: attending your talk after a heavy day. It is a positive high. I think, sir, thank you so much. It was a spellbinding session. Amrit, should we hand over to the chairpersons for their comment?
I think it's chairpersons are waiting. My dear friend Avinash is also waiting to speak something. So let's give them a chance.
Yeah, comments from the chairpersons, please.
Yeah, Avinash, the co-chairperson. Any comments?
Yes.
Avinash, unmute, please. Unmute yourself.
Well, I hope you can hear me.
Yeah.
All right. Thank you, sir. Thank you. An absolutely captivating talk, sir. And I think what particularly resonated with me was the fact that once a person or once the therapist is aware of all the motivational interviewing techniques, the first interaction with a reluctant teenager who's probably been hoodwinked into coming into the clinic, so that first interaction need not be a traumatic one. And I think once such teenagers wise up to the fact that their parents are not to be trusted as to where they are being taken, and particularly if the first interaction with the therapist or the mental health professional had not been a positive one, and if the therapist had gone in with a full frontal approach rather than using the sometimes counterintuitive approach of the motivational interviewing technique, it can prove counterproductive. So to that end, I think you have really primed the trainees as to brushing up on all their motivational interviewing techniques, and all the simple examples and analogies that you gave were an absolute treat to hear. I've certainly benefited immensely, I would say, although I don't really work a lot with substance use disordered individuals. Once again, thank you so much. I really enjoyed your talk. Thank you, sir.
Lal sir, over to you.
Yeah, okay. So, I mean, Vivek's talk has always been elegant, and he has not disappointed. Everybody has got some take-home, must have taken home some messages from him. As far as I'm concerned, there are 2 or 3 things. One is that psychiatry is not mathematics. ICD and DSM are fine, they're very good, but if it is 6 out of 9 or 5 out of 8, then you are diagnosed. You have a stamp, which is not the best thing possible. I mean, that conceptual thing is missing. It's just clearly mathematics. The second thing is the desire to prove something, prove that the patient is wrong, he's at fault, and the desire to set things right. I mean, that is something very, very inbuilt in us. We've come here and we should set things right, which is very innate. I mean, even if it is at a subconscious level, it is there. We should set things right. And the third most important thing, probably the most important thing, is that drug addiction, the central feature is loss of control. That is something that we need to focus on, loss of control. So with those words, I'd like to thank the organizers for calling me, and thank you, Vivek, for a wonderful talk. Thank you, sir.
Dr. Tufan, sir.
Thank you, Dr. Vivek. Your deliberation has been wonderful, enchanting, and quite enlightening. And as Dr. Lal observed, the central message of your talk is that drug addiction is a loss of control, as it is also in many other psychiatric disorders. But I want to make 2 or 3 points that came across my mind when I was listening. This luxury of planned therapeutic sessions is not affordable by many psychiatrists in our country who really cater to the persons with problem, or teenage adolescents with drug problems. They are taken to general practitioners much more than us. That is the fact, because everyone does not go to a tertiary psychiatric hospital. Our country is a large country, and the fast caregivers are very few. And we suppose Amrit is there seeing 100 cases a day. If one addict,
Sir?
Amrit is seeing 100 cases per day. So where is time for him? If the person of addiction is come to plan him throughout, plan a thorough psychotherapeutic session. So maybe we have to have some brief version where we can see. And taking cue from your level, your mother panicking that his son is addict may not be true always. And maybe in all spirit, we have to have a concern for the parents who bring their children, labeling as addicts who are not sure. And maybe the over concern of the anxiety is something like a over involvement, a high expressed emotion that makes them bring this. These are the concerns you have to address. Because if you have to look at the community at large, these are the things, thoughts come to my mind. And maybe
Thank you so much, sir.
In the next step, I will expect Vivek to answer this. And because we'll call him again because the video is pending.
Yeah, the 15-minute video is.
Thank you, sir. First of all, let me thank Dr. Vivek Benegal, sir. Extremely brilliant topic, the way he dealt with it. And I think we unlearned a lot of things, sir. I don't know how much we learned, but I think I unlearned a lot of things. That is very, very important. The way we deal with somebody in the first instance is the most important aspect. That's where the trust and the belief comes into the whole treatment process. Thank you so much, sir. As sir told, your video recording is remaining. I was desperate to watch that, but then it was little. Dr. Rakesh, sir, thank you so much. We've seen you after a long time. We've always been seeing you, person to person. Thank you for your wonderful deliberation. Dr. Avinash, congratulations. You're the youngest AO of CIP, and then we're happy to have you here with us, such a busy man.
Thank you. Thank you for inviting me.
Thank you so much.
Thanks, everybody.
A lot of
Thank
people.
Thank you.
Thank you so much. Good night.
So nice.
Good night. Next.
Thank you, sir. The video is pending, so
Okay.
you have to come with a
November end or December, you are invited, sir.
My take is that as told in the outset by Dr. Vivek Benegal, he deviated from the normal biological discussion to a more practical one.
Wonderful, wonderful.
And next, I expect him to be more practical, directed at the community itself. And
that is
Absolutely.
a different
Wait.
kettle of fish altogether.
yeah, yeah. Aap ho na.
Good night. sir.
Okay.
We can.
Thank you so
invite
much.
again
Thank
and
you so
again.
much. It was
Good
great.
night. Good night, everyone. Thank you.
Simply great.
Okay. Bye.
Invitation
Thank you,
for
sir.
you is constant. 2 Thursday musing up to Bhubaneswar, it is constant from my side.
Okay. All right. Thank you.
Bye.
Bye. Good
Thank you, sir. I think we can close the meeting now, sir.
Yeah. Pawan,
Pawan?